We are live now, doctor.
Yeah,
Naresh,
Chittaranjan,
sir.
you
can
start.
start the session.
Yeah. Okay, then I'll start.
Yes, sir, please.
Okay, so good evening, all. Once again, we welcome you all for an interesting, what you call, felicitation of the winners of the images. So this will be for the first 6 months of this year. So we will be having close to 18 presenters with 18 images. And as we have been telling earlier, there is no copyright issue involved. If the people who are what do you call submitting this, they can submit the image elsewhere. If it is getting accepted, we don't have any copyright issues over that, number one. And number two, the time is going to be very short for this 1 hour presentation. So I request all the presenters to make their presentation for just a minute. No need to thank anyone. Straight away get into the business. And at the end of the 3 images or each month's presentation will be having the discussion by our esteemed panelists and our members of the imaging committee who will be introduced in detail by Dr. Chittaranjan. And we'll be making it very short and crispy so that we can finish it on time. Over to you, Chittaranjan.
Thanks, Naresh, sir, for the kind introduction. And every month we conduct this VRSI image and video competition. In the VRSI images team, we have Dr. Naresh Babu, myself, Chittaranjan Misra, Dr. Unni Krishnan Nair, and Dr. Sangeet Mittal. And we have our secretary, Dr. Manisha Madam, who also helps us in this. And for this evening felicitation ceremony, we have an esteemed panel consisting of Dr. Rajiv Raman, Dr. Padmaja Kumar Rani, Dr. Anand Rajendran, and Dr. Binod Kumar sir. So without wasting much time, we will go to the award-winning images for the month of January. As Dr. Naresh sir has told, I will be announcing the names of the winners and their images. We'll see after all the images we have showed for particular month. We'll have the comment and the compliments by the panel and all our EC members of VRSI and our image committee members. So coming to the third prize for the month of January 2025, it's Dr. Arman Dawar. Dr. Arman is from Girdhar Eye Hospital, Kochi, and this is the beautiful image which he has titled as bilateral occlusive vasculopathy with rough spots. This is in a pregnant lady, anemia-induced occlusive vasculopathy. This is the text he has submitted for this image. May I invite Dr. Arman to please speak a few words about this image. Dr. Arman, please.
Yes, good evening, everyone. Thank you so much for this recognition. So this image was really interesting when this patient presented to our OPD. She was a very young female and she just delivered a few days back. And she had a systemic profile, a very complex systemic profile. She had this pregnancy-induced hypertension with anemia of hemoglobin just 8. And she also had SLE. And also during pregnancy in the last trimester, she had received 8 doses of magnesium. So we were correlating all the things, and there were not many symptoms. She had mild diminution of vision in both eyes, with this picture of multiple hemorrhages involving temporal and inferior quadrant, and they were quite symmetrical in both eyes. So which was a very unique finding, and there was mild subretinal fluid in the right eye, whereas there were hyperreflective layers on OCT in the left eye. So we took these pictures and we thought of submitting it here. And systemically, we got the blood investigations done, and we correlated it with the occlusive vasculopathy, which led to choroidal infarct, because pregnancy in itself is a hypercoagulable state, so which can lead to such findings in such patients. So in pregnant females, we should always take a holistic approach. We should look at the systemic findings also along with the ophthalmic findings.
Thanks, Dr. Arman. Yeah,
Yes.
point very nicely taken and a very beautiful image, ultra wide field images you have taken. We'll come to the discussion. So again, congratulations, Dr. Arman. He wins a certificate and 2,000 rupees for this beautiful image. Then we'll go to the second winner, Dr. Vipin Rana. Dr. Vipin is Associate Professor at Command Hospital, Eastern Command, Alipur. Dr. Vipin is stuck with some hospital emergency, so I will be displaying this image. This is the award-winning image, Takayasu retinopathy as the initial manifestation of Takayasu arthritis. You can see this is a FFA image over here and ultra-wide field image. And this is the text he has supplied, he has given for this particular image. And for Takayasu retinopathy, Takayasu arthritis related retinopathy, particularly the FFA things, these are characteristic findings, and we will discuss or we'll listen to our panel in detail during the discussion. Then coming to the, again, congratulations, Dr. Vipin. Then coming to the first winner, Dr. Sisir Varghese. Dr. Sisir, a very good friend from Amita Eye Hospital, Tiruvalla, Kerala, and he is a very habitual winner in almost all the image competitions. This is a beautiful image we can see, fading glory. So a very nice picture of NVE, and after laser NVE regresses. It's nothing new, but the way he has captured the image, and this is the description he has given in a patient of SLE retinopathy. The NVE was there, and after the laser, how the NVE has.
Chitranjan, I think Shishir is connected.
Yeah, Sisir, can you please tell?
Yes, sir. This was a 35 or so female with a known case of SLE retinopathy on mycophenolate, treated by her rheumatologist. So she came with one eye vitreous hemorrhage, and the other eye, the left eye, had these features of this C-fan kind of neovascularization, but pointing from the vessel onto into the vitreous cavity. So I got this. It's actually a color image, which when converted into a red-free using the Mirante imaging machine itself. And then these are the pre and the post photos. So I did not do an FFA because for some reason the physician did not allow her to did not give a clearance for an FFA. But through the imaging, Mirante imaging itself, we could see the areas of CNP very nicely. So then she underwent a targeted photocoagulation to the areas of this ischemia. And then post laser, you can see how the C-fan neovascularization is kind of faded and it's like withered like the branches of a tree. So these are both actually red-free images taken from the Mirante imaging.
Yeah. Great. So again, congratulations, Sisir. Sisir wins 5,000 rupees and a certificate. So before we move to the award-winning images of February, may I request our panel to say a few words to start with this particular red-free image of Sisir. So Dr. Vinod, sir, can you please put your words on this?
I think, thank you for having me here. These were beautiful images, Shishir. And I think it highlights the fact that sometimes we really don't need to go into those, fancy investigations and say invasive angiography. All you need to do is red-free images, especially for vascular changes. And I think the way this, angle has been taken, it very well highlights that this is a raised NV, a kind of C-fan envy. So again, beautifully captured. And as Chitranjan said, it need not be a very rare image. It's just the way a picture has been taken makes it unique.
Yes, sir. Thank you, sir.
Beautiful.
So, yes, sir. Thank you. So regarding the Takayasu arthritis, may I ask Dr. Anand, sir, to say a few words the FFA regarding the FFA, Takayasu arthritis?
Beautifully captured again something which we've seen, but to get that pruning well in one shot and with such a wide field view, I think that really encapsulates how beautiful this is and all the different faces. I think that's what makes it so spectacular and unique. And it's not easy to get these images. So when this is there, I think it's absolutely on to, appreciate it. So congratulations. First of all, it's not a common disease. So to get it and
Yeah.
then to capture it and bring it forth, I think deserves a lot of appreciation. Congratulations. Yeah.
Yes, sir, definitely. Thank you, sir. So again, regarding the third prize winner about the occlusive vasculitis image, may I ask Unni sir, especially the images are nicely taken, but like only the focal part, like one portion only is affected, temporal part they have captured beautifully. So any thoughts on that, like why it's spared the rest of the retina or something?
So again, brilliant images here. I mean, there is one particular feature about choroidal infarcts. It's called the amalric triangular sign. And that is the
Okay.
shape you see. The triangular shape pointing towards the posterior pole is very characteristic of choroidal infarcts. And you can have it in any quadrant basically, but here maybe it is the circulation. It is the most sensitive circulation that has been affected. One more interesting thing, just a quick note, in the right-hand OCT, you see a ballad. Bacillary detachment, you can see it very carefully. If you look, you can see a bacillary detachment
You're
also.
telling the right eye, right?
In the right eye, yes.
Yeah.
So it is probably a bacillary, because the image is not that clear, but it looks like a bacillary detachment also. So which is very interesting that you get bacillary detachments in uveitic elements. You can get bacillary detachments in any element in which the SRF rapidly occurs. But here, this could be a possible publishable thing if you have got it in a occlusive vasculitis producing an SRF. If it has not been shown to be published, it could be looked.
So in addition to the award money, they can get one, PubMed score.
Possibility, yeah. But the image has to be looked at in high magnification. It is a little bit,
yeah.
Okay, great images anyway. But the triangular choroidal sign is very beautifully seen in all the.
Yes, sir. So again, congratulations to all the winners of the month of January, and with this, we move to the month of February. So for the month of February, see the third prize. Yeah. So congratulations to Dr. Vani. She wins the third prize for the month of February. Dr. Vani is from MMJCI Hospital, Hubli. And this is again, the beautiful image of Indiac laser hyaluronic for the premacular hemorrhage. And we know we almost all of us we have done this, but see the way they have captured the image, so beautiful. They have captured the image, which this is the description she has given. The typical young man coughing, then valsalva retinopathy, and they have done this laser. So may I request Dr. Vani to say a few words about this image?
Yes, sir. Thank you for having me. So this was my first YAG laser hyaluronic, which I had done in the beginning of my second year of fellowship. So he was a young boy with valsalva retinopathy, as you can see here. And my laser parameters were using the focal bar grid laser macular lens. And my laser parameters were 2 millijoules of power with anterior 250 defocus. And I could get it within 4-5 shots, luckily. So that's it.
Okay, great. So I always remember, during our fellowship time, Naresh sir saying that you have to do this laser so that it hits like a bullet. The power should be high and it should go and hit like a bullet. So Naresh sir, your thoughts on this and also the inverse drainage quickly, please.
No, actually, Chitranjan, if you remember, I think we have a similar image in the cover page of Payment, the current edition.
Yeah.
Correct. Second thing is actually the most important thing about this particular thing is it's not subialyid hemorrhage, it's a subialum hemorrhage. So from the subialum space, now in the second picture, you can see the blood has gone to the subhyaloid space. So most of the time, actually, this valsalva is subialum hemorrhage. And once if it is completely drained, actually that bleb will sometimes mimic like a CSR number 1. And number 2, regarding this inverse drainage, I think we have published in the cases where the lower edge of the hyaloid hemorrhage is straddling the fovea, it is dangerous to hit because sometimes we might go for a foveal bone. So in such cases, we hit at the top, that is a non-dependent part of the subiolum hemorrhage. And then we'll be injecting just a 0.3 cc of SF6, make the patient lie prone for a day or so. So all the blood will express through the superior hyalodotomy, which we have made. And we call it as inverse drainage. I think we have published close to some 30 or 35 cases.
Yes, sir. Thank you very much. And again, congratulations, Dr. Vani. Dr. Vani wins third prize for this, 2,000 rupees and a certificate. Then coming to the second winner, Dr. Jigu Krisin. Dr. Jigu is from Arvind Eye Hospital, Madurai. And this is the beautiful image, spotlight on site. He has captioned it as spotlight on site, and it's a capillary, hemangioma. May I request Dr. Jigu to please speak a few words about this image? Dr. Jigu, are you there? Okay, I think he's traveling. So whenever he joins, we'll.
Oh, he must be there. At least not traveling.
Listen to him. Dr. Jigu, are you there? Jigu? I think he's not there.
Sir, am I audible?
Jigu? Yeah, Jigu, please tell, Jigu.
I said, first of all, thank you for the consideration. In traveling, there'll be some disturbances in the audio, sir.
Okay.
So this was an incident finding who came for central supply. The victim was 6'6" and he was nil systemic. So this capillary hemangioma basically they're red pink tumors arising from retinal layers and protruding into the vitreous as endophytic tumors, and they can be juxtapapillary also peripherally. Imaging modality plays very crucial in the plan of management. If they are small, as in this case, we can very well. But we tried once eccentrics, and there was no change in the size. So after that, after one eccentrics we observed. Fine.
Okay, Dr. Jigu, I think we got it, and there is patchy disturbance in the sound also in the audio. So again, congratulations to Dr. Jigu. He wins the second prize, 3,000 rupees for this beautiful image. And now coming to the first winner, Dr. Rajiv Vardasani. Again, he is from Arvind Eye Hospital, Madurai. And this is the image, the managing chronic retinal detachment with cyst. And they have done buccal. We can see in the second image how beautiful the retinal detachment has settled. And if Dr. Rajiv is there, may I request Dr. Rajiv to say a few words about this particular image or the surgery. Dr. Rajiv?
Good evening, sir. Am I audible, sir?
Yeah. Yes, please.
Yeah. This actually, the patient came with a 26-year-old male, came with a defective vision in the left eye for 1 year. So when we checked him for best corrected vision, it was 612 pass, and he was diagnosed with nasal retinal detachment somewhere else, for which he was done the prior barrage somewhere else outside. So the now when we saw clinically, there was superinasal quadrant well-defined retinal cyst, and supraretinal dialysis was also there, with wide field fundus imaging showing the same retinal cyst. With this was macula on retinal detachment, so that is why he's having defective vision, BCVA 612. So he underwent scleral buckling with 287 with 240 band, cryotherapy and subretinal fluid drainage. And the 3 months post-op, you can see on the left side, sir, the follow-up, the retina was well settled with good buccal height, and the BCA was improved to 612.
Great. So definitely very great surgery and nice imaging also. You have captured the buccal, and you used which camera for this, Claris?
So wide field fundus imaging, sir. Claris.
I know which one. Claris, I think you used
Yeah,
Claris Montage. Yeah.
Yes, yes.
So again, thank you. So again, congratulations to all the 3 winners of February, and again we welcome Dr. Padmaja Madam has joined with us. So may I request Dr. Padmaja Madam, if you could see this image, your points on this, like cyst, cyst with RD and managed with buccal. Yes, ma'am.
Yeah, I feel these kind of cases should come in cover pages of everywhere, how the buckle can work wonder. And the
Yeah.
most important is the cyst, not only the superior nasal cyst, sometimes you can even have this chronic retinal detachment where you have macular cyst. And that also
Yeah.
beautifully disappears. And one can actually, you can do a OCT also, you will know very clearly that, the cyst has disappeared and collapsed because
Yeah.
seeing is
Yeah.
believing. So beautifully
Yeah.
captured. Only one doubt was it really means could you drain there means subretinal fluid, because many times when there is a cyst and all, it's not possible for you to actually drain unless there is a chronic fluid underneath, because in this it's not very clear whether the detachment was significant enough. So the SRF drainage was able to attempt.
Yeah.
Yes.
The SRFD was done above the medial rectus, just
Okay.
above the.
So, yeah, beautiful.
Yeah, sir, Padmaja Madam and Naresh sir, both like one query on behalf of all the beginners. We need not drain the cyst fluid, right?
No.
Don't touch.
That's what.
Don't touch.
Yeah,
Never
we
touch.
should not touch it.
In
Yeah.
fact, I got doubt. That's why where exactly it was done, because there must be more fluid tracking in the medial. That's why they might have done it. Otherwise,
Yeah.
there's no need to touch anything. It will just collapse.
Yeah, great. So again, we welcome Dr. Rajiv sir has joined. So again, thanks sir for joining despite a very busy schedule. Any of the images, if you could see sir, your comments on that for the February month images. No, I think he has not. So okay. So then we will go to our panel, Dr. Binod sir. Any thoughts on this particular image? Retinal capillary hemangioma right on the disc over there. It's not a very peripheral capillary hemangioma. Any thoughts on this, Binod sir?
It's a beautiful image again. So if I was there, I would take him to a conventional camera and probably
Yeah.
take a zoomed up picture as well. So
Yeah.
capillary hemangioma, especially sitting on the optic nerve head, they are not so common, but they are not very rare either. So I've seen a few ones, the ones which leak, they are always a challenge to treat because you can't laser them directly. PDT unfortunately is not available, so we have very limited options. But the one which is sitting quietly like this probably does not need to be touched. We just wait and watch, and at times they can happen as an isolated thing, but one should not forget to investigate for VHL syndrome.
Yeah. So, Dr. Jigu, if you can join again, like, did you follow up this case? What happened to this case after a few months? Dr. Jigu?
Hello, sir.
Is your internet? Yeah, Jigu,
Sir,
what
the
happened?
patient is doing fine, sir.
Okay.
Hello.
Chitranjan,
Yeah.
this patient is called every 6 months, Chitranjan. No
Okay, sir.
treatment,
Okay.
only regular follow-up with the serial photographs and its comparison.
Great. Okay, sir. Thank you, sir. So the first image we have already discussed. So with this, we'll go to the award-winning images for the next month, that is March. Okay.
Can I make a small comment?
Yes, sir. Yes, sir. Please.
Chitranjan. So the first, the yaghyler.me. I think
Yeah.
another wonder you see is when you do OCT of these patients post-operatively. So you get a premacular cavity kind of thing. And you know, that's again startling images. You see those ILM which is extending far beyond in front of the retina. And that will confirm, as Dr. Naresh said, most of these changes, hemorrhages are happening in the subialum space. And also, if you see, there is fine white line in some of these images, subialum hemorrhages at the edge of the, hemorrhage. So if you do OCT through those white lines, you will see a small peg-like structure in the outer retina. That is what we labeled as arcus retinalis. And I think in this patient also we could see, and it's always, these cases are always very interesting.
Sir, I think you published this in European journal or somewhere.
Yes,
This
yes,
one?
yes. The
Yeah,
Arcus
correct.
retinalis is published in European journal, and
European
we
journal.
published this premacular cavity long back, I think around 2006-7 in OSLI retina.
Yeah, sir. Okay, sir. Congratulations to you too, sir. Great. I remember reading that article, European journal. So thank you. So again, now we move to the month of March. So coming to the third prize, Dr. Chakram Priyalakshmi. Dr. Chakram Priyalakshmi is from Arvind Hospital, Madurai. And this is again the image of senile retinoschisis. She has captioned it as crystalline illusion, a case of senile retinoschisis. And this is the text she has given. The image is beautifully captured in Aiden camera. Dr. Chakram Priyalakshmi, if you are there, can you say a few words about this image?
Good evening, all.
Yeah.
This photograph of right eye is a case of senile retinoschisis, and it demonstrates bullous retinoschisis in the infratemporal quadrant. And as you can see, the beaten metal appearance of the inner retinal layers with the overlying blood vessel, which appears darker in color, and it shows shadowing also. As we know, senile retinoschisis is the characterized by splitting of the neurosensory retina, primarily outer plexiform layer, and it mimics retinal detachment. So we have to differentiate from retinal detachment. Most of the senile retinoschisis are asymptomatic, and we will observe only, and most of the time they don't need treatment. But the incidence of RRD in case of senile retinoschisis was estimated to be somewhere around 0.05, and most common location is infratemporal quadrant, and outer retinal break are more common than the inner retinal break. And outer retinal break you can see in 6% of the senile retinoschisis. Thank you.
Okay.
Chitranjan,
Again,
it appears
congratulations.
more like a dislocated crystalline lens, actually.
Yeah, sir. But that will be little inferior, I think. This one. Yeah, but you told rightly. So congratulations again for this beautiful image, and she wins 2,000 rupees and a certificate for this. That's from Priya Lakshmi. Then with this we come to the second winner, Dr. Anand Tenkar. Dr. Anand is VR consultant in Vasan Eye Hospital, Vrsi. And this is again, another beautiful image. Unfortunately, unlucky for the patient, a large break at the posterior pole with retinal detachment with PVR status post blunt trauma. And this is the description Dr. Anand has given for this. Can you please describe this image? Dr.
Yes,
Anand Temkar.
good evening, everyone. So
Yes.
this was a case of a 10-year-old boy. Parents came to know there is diminution of vision in right eye since a month, but they gave a vague history of tennis ball injury 2 years ago. So now this was the presentation, a large break at the posterior pole with the rolled over edges and PVR changes in the retina. Vision was counting finger close to this. Actually, I was a fellow at Dr. Manish Nagpal's in Ahmedabad. At that time, this image was taken. So we did encirclage, DMV, and silicone oil infusion. So last follow-up we did in July first week. So his vision was finger counting 3 meters at that time.
Okay, so very difficult case to manage. We'll come to our panel regarding the discussion. But anyway, congratulations.
Chitranjan?
Yes, sir.
Is he having the post-op picture of this case?
Dr. Anand, are you
like
having
to
the
see
poster?
it.
Sorry, sir, I completed my fellowship in February, so I was unable to keep follow up this personally.
Okay, good. So nice documentation. Again, congratulations, Dr. Anand Temkar. He wins the second prize for this nice image. So, with this, we come to the first winner for the month of March, Dr. Abu Muazzam Parvez. He is from Netralayam, Kolkata. And this is the the symmetrical image, canvas of concern, rock spots across the retinal terrain, whispering a deep lying disease. So again, this is a description he has given for this image. If Dr. Muazzam Parvez is there, please describe this image.
A very good evening to this august presence. So this is a 26-year-old student who presents with bilateral diminution of vision with a history of recent bout of fever and chills a week back. On this image, we can see multiple retinal hemorrhages in the superficial capillary plexus with small, round, white, pale lesions with a surrounding red halo. The fovea shows some amount of subretinal heme along with SRF. The central foveal area shows blood accumulation in pre-retinal, retinal, and subretinal space, which can also be appreciated in macroaneurysms. Central clearing halo with peripheral dense retinal hemorrhage, which is corroborative of hematological finding, with some cotton wool spots around the arcade underlying the flame-shaped hemorrhages. Flame-shaped retinal hemorrhages on either side of the disc outside the arcade. The hemoglobin was found to be 6 and a diagnosis of anemic retinopathy was established. Further systemic examination revealed acute lymphocytic leukemia for which the patient underwent bone marrow transplant. Thank you.
Great image. So, Dr. Muazzam Parvez, which camera you used for this image?
Sir, for this we've used a Topcon Maestro montage. Manual montage is done on a Topcon Maestro 2.
Okay, great. So, okay, congratulations. We'll go to the discussion for the month of March. The images, may I ask Dr. Anand Rajendran sir, your thoughts on this particular image, the raw spots in anemic retinopathy in a patient of leukemia. Anand sir?
Yeah, again, very beautifully captured. Again, not something very common, and it's very nice to see. And both the montages are very symmetrical also. So that also, as you mentioned, he had to do it manually. It's a manual stitch, not an auto stitch. So that again is also skill to the to the individual who's done it, and Dr. Parvez. And as he's mentioned, the systemic features. I mean, this is a textbook kind of classic case for anybody who's new to retina. When you see this, it should ring alarm bells. Absolutely, you need to go and check with the hematologist and the patient. Peripheral smear is absolutely critical. And this is an example of a case where, retina specialist or an ophthalmologist makes a difference to the patient's life. So it's very important to, spread the word about cases like this. Beautifully captured. Do you have images of, after the patient underwent treatment? Did the patient get better or any information?
Very sad to say, sir, but after the bone marrow transplant, the patient had trouble and he passed away a month
Sorry
back.
to hear that.
Yes, sir.
Yeah.
Okay. Right.
That's the unfortunate part. Just to add, Anand sir, these state of rock spots, when we get these hemorrhagic spot, these patients, in addition to the anemia, they have actually pancytopenia, and the low platelet count that actually contributes to this. In addition,
excessive hemorrhaging, yes.
Yeah. So okay. So Padmaja madam, your thoughts on any of the other images? This image in particular.
Yeah. I think this posterior pole breaks. I did had a chance to actually he was a pathologist, and the break was not exactly at the macula, but just next to the fovea. So it developed during the course of the vasculitis, and he had a earlier history of retinal vasculitis in the periphery, and then over the time we did some laser and all. We don't know how it happened. Suddenly, one day he presented with a posterior pole break next to the fovea. So the surgery was, and I actually did the surgery and then put gas, and then luckily everything settled and he remains with 20/20. But the posterior pole breaks are actually scary. But I think if we do carefully ILM peeling and then everything, and if required, they can settle with comfortably if they're there. But in this there is some PVR changes are there.
Yeah.
And
So-
one thought process, and all these pictures are so beautiful, might have been captured by the, probably in our setup, it's all optometrists who capture the photographs. I think we should also give credit to, along with our keen observation, I think as a co-author, they should also be mentioned.
Yeah. Very valid point, very important point. So all the optometrists and ophthalmic photographers,
Correct.
And all our email, whoever is taking the photo, we should give them the credit.
Yeah.
Yes,
That name also can be mentioned, and that will be very nice.
Yes, ma'am.
So just
So,
a small point. I wanted to make a small point about that image.
Yes, sir. Yes.
Just one of the challenging things is how to do a pexy around it. Because on one edge you see the fovea very close, and I mean, I just want to sensitize people to the potential use of fibrin glue once it is being used in Regmetoni's RDs now, and maybe if not all over, but in the edge where the laser cannot be applied, you can see the fovea is slightly on the edge. After the hole becomes much smaller after reattachment. I mean, I'm not saying in this patient, but all of us can keep it in mind that we can use fibrin glue for covering breaks, and maybe doing a laser at a later stage when we have some sort of retinal reattachment.
Yeah, one needs to
sir, very
be
valid.
careful about subretinal migration as well of the fibrin glue. That can cause sometimes intense reaction.
Yeah, Dr. Mudit got the award for this now Red Brookler award. Yeah. So, but very valid point. So regarding the other image, that senile retinoschisis, any points from any of our panel, our members, is senile retinoschisis?
I'm very interested in that just for one reason. You see a magnification of the blood vessels, and it looks like maybe the lasers have been magnified by the convex shape of the schisis, and they appear closer and larger. So it's a very good optical illusion that is happening. All the blood vessels are thicker, and that is probably because of the convex refracting or reflecting surface that is happening there. I think that is a very nice thing to see here.
Yes, sir. That is actually a term is there. So I'm just forgetting in the map when the periphery is there.
You call it the Greenland effect.
Yes, something like that. So in these wide angle or ultra wide field images, the lesions those are at the periphery, they appear disproportionately larger than
this is not the periphery. You can see the blood vessel becoming thick immediately at the edge from the schisis. You see the two blood vessels, the artery and vein. You can see them immediately becoming thicker over there, and that is a very, I mean, it is worth looking into whether intraocular lesions which partially transmit light cause magnification.
Okay. Correct, sir. And in addition, the age-old question for all our fellows and residents, those who are watching, so differentiating between a retinoschisis and retinal detachment. So they ask always, and you should be prepared. We're not going to the details of that. So with this, we congratulate all the winners of the month of March, and we'll be moving to the month of April. Bear with me, please. So we come to the month of April. So the third prize for the month of April goes to Dr. Serena Thomas. Dr. Serena Thomas is from St. John's Medical College and Hospital, Bangalore. And this is the OCT image, syphilitic placard masquerade no more. So this is the image with the telltale signs, very subtle but very pathognomonic signs, for which she has won the third prize for the month of April. This is the description. And congratulations, Dr. Serena. Can you please elaborate on your OCT image here, please?
Thank you, sir. Thank you for the opportunity. My image is not very fancy, but it's a very typical presentation, as you said. So it was a case of a 34-year-old male who was a known retropositive, who came to us with decreased vision in the right eye for the past 10 days. And on examination, he had a placoid lesion at the nasal to the fovea. And his OCT showed thickening and hyperreflective nodularity of the RP choroid complex with focal disruption of the ellipsoid zone. This is actually a typical presentation of acute syphilitic posterior placoid retinopathy with the background of HIV positive. We sent the patient for treponemal and non-treponemal tests, which came positive, and the patient improved very well with the IV penicillin.
So what test you did, the VDRL or
we did both TPHA and VDRL.
VDRL both? Okay.
Yes.
Correct. Okay. So thank you, great. So nice documentation and nice diagnosis. Congratulations, Dr. Serena. And we'll move to the second prize. The second winner is Dr. Rohan Suresh Menon. And this is the image titled Crimson Tide Catch the Infiltrator. This is the description he has given for this particular image. May I request Dr. Rohan Suresh to please elaborate on this image.
So this was a 55-year-old male who was a known case of acute lymphocytic leukemia. He was on remission, but he came with complaints of severe headache and sudden loss of vision since 10 days. So he had an OPL vision with restricted movements, painful restricted movements, and fundus showed like an infiltrative optic disc edema, multi-layered hemorrhages, both the combined occlusion. And MRI was also very suggestive with both cerebral and cerebellar involvement, with optic nerve involvement, and also fat and extraocular muscles being also showing changes.
Okay, so thank you. So I just forgot Dr. Rohan Suresh is from SJI Hospital and Research Institute, Kerala, and nice image. So just to ask, was it also additional like CRAO kind of, because we can see the inner
yes,
retinal
there was
layer.
like a combined occlusion.
Combined occlusion, yeah. Okay.
Yes, sir.
Thank you. Got it. So congratulations for the second prize. And coming to the first prize for the month of April, Dr. Kunduru received. This is the nice image, Crismotio retitri. For this particular image, she has got the first prize. May I request Dr. Rishita to please describe this image?
Good evening, sir. Good evening, all. This was a case of 34-year-old male who came with blunt trauma, and the fundus image reveals a Christmas tree pattern of commotio retina resulting from blunt ocular trauma. It also shows vitreous hemorrhage, and these findings collectively highlight the significant retinal injury due to blunt trauma. Thank you.
Thank you. Dr. Rishita is from Arvind Eye Hospital, Madurai. So congratulations again, and we'll go to the discussion about these three images. Coming to this particular image, how often we see actually commotio retinae along with vitreous hemorrhage? It looks like little unusual. Any of our panel, Anand sir, Vinod sir?
I think it's not unusual, Chitranjan. We do quite see quite often this. It's a treat, whenever you get such a patient, in the sense that it's always a award-winning image when you have to spot it, because you have to match it. Once you see it, everyone sees it. So very typical picture of commotio retinae, but what makes it special is we see lots of commotio retinae, the tree which it makes, and vitreous hemorrhage is always, it may happen. It's not that unusual, but it's quite accompanying. And once it goes away, we might be surprised. There might be some element of subretinal hemorrhage as well.
Okay, great, sir.
Yeah, true. Actually, you need to catch it within that window. You need to be lucky enough to catch it within the window, and then you need to get that image in properly. Yes, like Vinod said, if there's a partial avulsion of vessel, you can very well get this. It all depends on the extent of that coup contra coup effect that leads to all this. So, I mean, beautiful image. Congratulations.
Yes, sir. So thank you and congratulations, Rishita. And coming to the second winner of Dr. Rohan Suresh Ninan, this one, may I ask Padmaja Madam, this particular image in a case of a leukemia patient, unfortunately patient presented with a combined occlusion and a very angry looking retina. and the patient was already on treatment, as the author has told. And like how frequently we get these are like the presenting signs to the ophthalmologist, who is leads to the diagnosis. Is it so common, or how it is, Padmaja madam?
I had actually opportunity of visiting, having two ALL patients coming to the same OPD, and which presented with, we diagnosed it as ALL, just they presented with not like this hemorrhages, but with this multiple pinpoint neurosensory detachments in a young patient. Then it was very unusual. I did not see any signs of hemorrhages as such, but unusual desensitization. So all these things, just say because we were just thinking it was not looking like a typical multifocal CSCR. These were the differentials which were coming, not even looking like weak hedge. I just had that, along with angiograph, I asked them to go for a blood picture, complete blood picture, and that clinched the diagnosis. So sometimes these are, and especially if it happens in this patient, is the other eye also, fellow eye also had the similar changes?
No, the other eye did not have these changes, man.
Usually when we have bilateral like this hemorrhages and everything, definitely it points to the systemic systemic underlying blood dyscrasia, and we always try to rule out underlying blood dyscrasia. It could be leukemias, it could be severe anemias, and the dark hemorrhages also suggest that there could be under pancytopenia, as we were discussing earlier. If there is a thrombocytopenia, you can have a dark colored hemorrhages as well.
So for the sake of the audience, like it is like both ways. Like the patients can be diagnosed with the underlying dangerous disease from the ophthalmic presentation, and vice versa. The patient already diagnosed with blood, hematological malignancy and presenting to the ophthalmic. So we need to be vigilant about these images. Thanks for this. And regarding the third prize that Dr. Serena told, I wish Dr. Mudit was there. He is always, discusses all this. But this is again, as Dr. Serena told, it's nothing fancy, nothing. But the OCT, it itself tells, it speaks about the diagnosis. We know we get these small nodular hyperreflective lesions of the RP and choroid, and on the overlying photoreceptor layer, some degeneration is there. So anything in addition to this, any of our panel or member want to add to this syphilitic plaque? Yeah.
And I think it's not the question of fancier striking images. I think most important is identification of this feature alone will clinch us the diagnosis. So I think that is probably that keen observation is what is actually, deserves appreciation. Yeah.
Correct.
Yeah, and I guess along that, if you have an IR image also, I mean, these are things people have to realize that, syphilis is making a comeback. And actually, there are more cases that we actually suspect. So I think it's very important for all ophthalmologists, general ophthalmologists also, to know that, these signs exist. And when you see something like this, what I call a stalagmite, appearance up and down, that should tell you a lot.
Yeah, it's a point very well taken, sir. So with this, even we congratulate all the winners for the month of April, and now we'll move to the next month, that is May. So for the month of May, the third prize winner is Dr. Anjana Mirazkar. So she is VR consultant in SD Desai, Pune. And this is the image. Look at this image. Asteroid hyalosis. Day in and day out, we see asteroid hyalosis. But you see how beautiful she has taken the image, and she has won a prize for this. Again, she is one of the habitual winners of VRSI image competition. So Dr. Anjana, please say a few words about this image and the imaging technique also.
Yes, thank you, sir. Good evening, and thank you, VRSI team, for again giving me prize in the VRSI image competition. So this was a 65-year-old male who complained of diminution of vision since 5 to 6 years, And on examination, we could see that this patient had dense asteroid hallosis. And actually, I had seen this case when, again, I was doing fellowship with Dr. Manish Nagpal. This image is captured at his place. But unfortunately, I couldn't follow up this case, and he was advised parasplantar vitrectomy in view of such dense asteroid, and he was complaining of diminution of vision. So unfortunately, I couldn't follow up this case. So I'm not pretty sure whether this patient got operated or not.
Okay, so thank you again. Congratulations. You win the third prize and 2,000 rupees for this beautiful image. We'll come to the discussion later. Then again, the second prize goes to again Dr. Muazzam Parvez. He is from Netralayam, BR Fellow, Kolkata. And this is the image, eye within an eye, symmetrical macular dystrophy. This is a case of bilateral benign concentric annular macular dystrophy. So, Dr. Parvez, please speak a few words about the image.
Hello again. So over here we have a autofluorescence image of both eyes of a 32-year-old lady showing central dark halo surrounding with perifoveal halo, surrounding which a darker halo is observed bilaterally. This halo lesion was surrounded by dot pigmentations and fluorescence temporal to the halo were also noted. Quite evidently, this is a bullseye maculopathy, and all the differentials for bullseye maculopathy were considered, as there was no history of any drug toxicity. And after all the systemic evaluation, we came to the diagnosis of bilateral concentric annular macular dystrophy. Thank you.
So, Dr. Parvez, which camera you used for this autofluorescence image?
For this, we have used Heidelberg Spectralis with the autofluorescence lens.
Correct. Good. Congratulations. So, we come to the first winner, Dr. Ashutosh Kumar Gupta. Dr. Ashutosh is from Army Hospital Research and Referral, Delhi. And this is the image, spectacle inside the eye, a chronic retinal detachment. We can see the B-scan also, intraretinal cysts. This is the description that Ashutosh has given for this. May I request Dr. Ashutosh, please describe this image.
Case of 40-year-old female who presented 4 months back. At that time, I was doing my MCH in vitro retina from PGI Chandigarh. It was very clearly, it was a case of old RD, subtotal RD, with there were multiple retinal cysts. Actually, this ultrasound photograph I was just taken for the curiosity, and it came out to be so beautiful. It appearing like a spectacle inside the eye. That's why I have submitted this photograph. It was just clinically it was visible. Even my consultant asked, why you have done the ultrasound when you can see clearly? I said, ma'am, just for curiosity. So that's why I submitted this case.
So now you can go and give a treat to madam also. That that day ultrasound is so good. That is just kidding. So very nice and beautiful image. So regarding these 3 images, again, congratulations to all the winners of the month of May. Regarding this particular image, any in addition to the imaging part, anything clinically we should give to our fellows or residents, Anand sir, Padmaja madam, chronic RD with cysts?
Learn, buckle, and do it.
Yes, yes, ma'am. Yes, ma'am. We have managed this case. We have done the buckle. There was a break inferiorly.
Yeah.
And retina setup, but she maintained the vision 2/60, which are pre-op and post-op. We have told the patient about this. We managed this case with scleral buckle, ma'am.
Yeah.
Yeah.
Yes, I was going to ask you about that. Whether this was a case with ideal case to do a buckle and settle it.
So we have managed
and you get a very good result. And keep doing ultrasounds in detachment cases.
Yeah.
No, I think we had a similar case. I think it's published in IGO as images. So like a similar thing happened, and there were so many cysts. In fact, we published it as, I think, probably a chain of cysts or something. Again, it was a beautiful image. And if you see here, once you look at the ultrasound and then look at the clinical photo in the, you can make out the spectacle without ultrasound also.
sir.
Yeah, exactly.
Just got
Yeah,
an idea. Maybe post surgery, you can do the ultrasound again, and you can say we can remove spectacles by just doing surgery.
surgery.
Doing VR surgery.
Doing VR, yeah, not plastic surgery, correct.
Refractive surgery by the retina
Yeah,
surgeon.
yes.
Yeah.
Refractive surgery, yes.
Yeah. So good. Again, just to add one more thing that sometimes patients come and they say that, sir, just for 1 week only the vision is less and all. You can tell that your eye is saying it is at least 1 year or something, because it is a chronic RD, you can say about that. Nice again, and Dr. Asutosh. And regarding this bullseye maculopathy image by Dr. Parvez, again, for our residents, the Kansky's book, when we, the bullseye maculopathy, all the causes, the possible etiologies are given. This is one of the etiologies, was Dr. Parvez told. And anything in addition to this, our panel, Dr. Anand sir, Vinod sir. Bilateral benign concentric annular macular dystrophy.
I think it's a very nice image, Chitranjan.
Yes, sir.
Especially the right eye, if you see the outer, part has a little canthus also in the right side.
Yeah.
So one
Yeah.
looks at it carefully. So it's a
Yeah.
typical bullseye maculopathy, and one would earlier we used to do ERGs and so many things to ascertain the diagnosis. But as we are relying more and more on genetic evaluation, so I
Yeah.
think nowadays it's very difficult to say what is the exact diagnosis without without doing the genetics. Many a times we do come across surprises when we think that clinical diagnosis is something and genetics tells us something else.
Yes,
Yeah,
sir. Thank you.
additionally, I think this shows value for doing autofluorescence.
Yeah.
In all these dystrophies, I think you get the best picturization, big depiction of pathology with autofluorescence in this. So I think this is probably the only image which is purely autofluorescence in this entire set until now. But just to go to show, I mean, there's great value for autofluorescence. Tells you about the metabolic picture too. Yeah.
Yeah, correct. So again, we'll move to this, the simple image, that is asteroid hyalosis. So whenever we see a case of asteroid hyalosis, that can also give an award to us. So Dr. Anjana has already told about this imaging. Any of our panel wants to say anything about the imaging when we see a case of asteroid hyalosis, any particular like fundus camera or anything we can take to document it, because we all know now that it can give us something more in addition to. Vinod sir, anything? Vinod sir?
Again, I think beautifully captured image. One of the highlights of hyalosis is they are better seen with the laser-based cameras. So wherever you have, for example, this was captured on Mirante. So where you don't have white light and you have laser, colored lights, combination of three lights, or for example, even on optos, you will see them much more clearly. And another imaging clue about them is when you do a fluorescent angiography, you don't see them. That is again something for residents to learn. So whenever you want to see through asteroid hyalosis, please do fluorescent angiography, and these will simply disappear. But a beautiful picture again.
Yes, sir. So with this, we welcome Kim sir. We are very lucky Kim sir is over here despite of his busy schedule. And I myself and all of us, we would love to hear from him about this, chronic RD, spectacle inside the eye. Kim sir, if you could see this image, this is the first prize winner for the month of May, a chronic RD, and the cysts were in a fancy pattern looking like the spectacles. Your thoughts on this this image and the management? Kim sir, are you there, sir?
Chito is not connected.
Sir, I saw his name somewhere.
No, it's not there.
Not there, huh?
Wow.
Okay. Okay, sir. Naresh sir, your thoughts on this?
No, actually, we have
Anything
discussed a
additional?
lot, actually, like as Dr. Padmaja told, no? Learn
Yeah.
buckle to solve this problem.
Yeah, yeah. Yeah. So again, for all our the youngsters, those who think that buckle is a dying or dead, and it's not like that. All of our panel, you can see all of our BRSA image or image team members, seniors, they are emphasizing on the buckle thing, scleral buckle. So we have to learn buckle. Whatever big machines are coming, innovations are coming in vitrectomy, we have to learn buckle. And recently we published that 300 cases of scleral buckle from a single institute. So for all of us, we should not think that without buckle we can just become retina specialist. That is a very clear-cut message. And also for all the aspirants for this VRSA image competitions winners. So like all the people who are submitting, you see, in addition to the science, a bit of poetic expression, like eye inside eye, or a philosophical thought or storytelling, that faces the award. And it's not about we the image committee members which are selected. It's based on the polling that is happening in a very neutral way, going to all the VRSA members, and by the polling it is happening. There is no EVM like manipulation or anything. So again, congratulations to all the winners for the month of May. Then we move to the month of June. So the third prize for the month of June goes to Dr. Tejaswita Verma. She is VR Fellow, Retina Foundation, Ahmedabad. And this is a very challenging case, intraocular glass piece. And this is the description. All we know that the image itself speaks. So Dr. Tejaswita, if you are there, congratulations, and please say a few words about this image and this case surgery.
Yes, sir. Sir, it was a 25-year-old male, young patient who had met with an accident due to with the windshield glass. It was a road traffic accident, and after that he had an extensive retinal detachment with an intraocular foreign body, which was a huge glass piece lying over the macula and apex pointed inferiorly. And then he was planned for intraocular foreign body removal, BMV, vitrectomy, and silicone oil tamponade was done.
So one additional question to you, Dr. Tejaswita, your images, the intra images, especially the posterior pole magnified images, have been very beautiful. Any particular tips you want to give, or you don't want to share your secret of award-winning images?
Sir, actually, it was captured with the Sony camera. So I think the credit goes to Manish sir for operating such like difficult cases. So
We all know
I
with
think,
the credit Manish sir, yes, yeah, beautiful images, beautiful surgery.
And the camera is
So
also
like what? Okay, any like the wide angle viewing system, what you are using during
so the
this
wide
image?
angle. So the lens that we are using.
Yeah, the lens.
Sir, it is Vogue wide field lens, sir. The contact lens.
Contact lens, yeah. I think that also makes a difference. But congratulations to you, Manish sir, and I believe that the outcome would have been great. Like in seeing this very challenging case, we'll come to the discussion also later. Congratulations, Dr. Tejaswita. Then the second prize goes to none other than Dr. Apurva Ayachi. She is very well known to all of us. She is from MMJC Eye Hospital, Hubli. And this is the image, not just any hypopigmentation. This is a retinal astrocytic hamartoma. And may I request Apurva to please describe this image.
Thank you, VRSI, for this opportunity. We had the good luck of having this patient who came just for headache, a 20-year-old woman. She came with headache, and when we examined the fundus, we found this lesion picked up just on routine fundus examination incidentally. No symptoms are attributable to this, obviously, like you can see, the macula is absolutely normal. This is also normal. The first image in this panel is actually a slightly color corrected Optos image. It is pseudo color. I have tried to bring out the color of the lesion closest to true color as much as possible. This is actually a retinal astrocytic hematoma. We can see on the multicolor image that because it is an elevated lesion, it is looking greenish. So any elevation on a multicolor will have a greenish hue. And the OCT of this lesion shows a very beautiful finding of NFL proliferation. Basically, the nerve fiber layer has expanded, and we can see a moth-eaten appearance inside the lesion with considerable backshadowing. Of course, it's not obscuring the RP visualization, but most of the retinal layers are not seen. These moth-eaten cavities or these cavities are probably suggestive of some calcification in this lesion. So this was a case of a solitary circumscribed retinal astrocytic hematoma, possibly stage 3. One must know that this is different from a solitary circumscribed retinal astrocytic proliferation, which is a scrap lesion, which is a lot different. It is arising from the deeper layers of the retina and the RPE. So this is an RAH, and it is different from a presumed scrap lesion. Thank you, Dr. Chitranjan.
Yeah. So thank you. Any specific systemic things? Did you find anything in this? No.
Yes.
Systemic?
So yes, we did send it to the physician. It was a 20-year-old woman. She didn't have any systemic symptoms or any cutaneous plaques. But yes, you have brought out the point that these are associated with neurofibromatosis and tuberous sclerosis complex. So the lesions in those phacomatosis are much more, they're obviously multifocal and bilateral. In a solitary case, the systemic associations are less.
Correct. Okay, congratulations, Apurva, again. And with this, we'll go to the first prize for the month of June. And yeah, the first one is Dr. Anugraha. Dr. Anugraha is head of VR in Mahatma Eye Hospital, Trichy. And this is the image. Please see this image: eyelash migration into the eye. So this is the description she has given. May I request Dr. Anugraha to please say a few words about this image.
Thank you, Chitran sir and VRSA for giving me this opportunity to be today here. So this is a case of 45-year-old male. He had injury to the left eye with nail. That was in 2014. But he presented to us only 6 years back. Now his best corrected visual acuity was 6/9. He had a corneal scar, which was self-sealed, and it was also pseudophakic. So in vitreous, we could see this eyelash sitting inside, but it was not causing any inflammation per se. And the patient also was quite comfortable. It was accidental finding that we saw. But still, we advised vitrectomy for removal of this foreign body, and patient was not willing, and after which he lost follow-up also. So yes, sir.
Okay.
That's it from my end.
Yeah. Okay. So thanks, Anugraha, but keep following up with this patient. Okay. So nice
Yes, sir.
image. Yeah. So again, I think we have Dr. Kim sir with us. Kim sir, are you there?
Yes. Is there?
Yeah.
I'm sorry, I was joined very
Yes,
late.
sir. Yes, sir. Good evening, sir. Good evening, sir, and welcome, sir. Sir, if you have seen any of these images, your thoughts on these images, like particularly this one, like how it's a rare thing, obviously, but in your experience, should we leave these patients like because there is no reaction, or we should intervene these kind of images?
No,
These kind of cases.
Chitranjan, I've never seen anything like this, but we have seen many foreign bodies in different formats. But I'm just wondering how the eyelash went behind and coming out of this thing. That is really surprising. How it happened.
Yeah.
What was the nature of the injury?
So it was nail injury, sir.
Nail injury? Oh, okay.
It had a corneal laceration also, sir. It was also self-sealed. The patient presented was only after 6 years after the injury. So before already it was repaired, and it was also pseudophakic also, sir.
No, the question is, how did the eyelash go in this direction? If it had been in the opposite direction, it wouldn't be surprising, but it looks like it has come pierced from the back, which obviously is not.
Yes,
So,
sir.
and then remaining quiet for so many years without any
Yes.
reaction again is really surprising.
Yeah.
Unless there was a scar, was there any scar around the base of the thing? Because I see some small pigmentation, but nothing beyond that.
Yeah. Yeah.
This
Yes, so
one,
there was a small scar was there. So collateral scar was there nasal to the disc.
no, but
And
at the
vision is
site of
6'9".
where the eyelash is pierced, like, just above the fovea, it's pierced, right? That's,
Yes, sir.
No,
Yes.
yeah,
sir,
that's
I
what
think
is surprising.
So it
That,
was not pierced the globe, sir. It was in the vitreous cavity, actually. It was not.
no, but
no.
is it
Anugrah Kim sir is asking about this particular, the
no, Chitranjan. I'm asking about the other side, just above the fovea.
Oh,
It
this
looks
one.
like it's inserted there. Is it? Or
Yes.
was
So, but it was in the
No, sir,
vitreous
this
only, so it was not pierced that there where you're
Oh,
in
telling
the
the arrow
vitreous,
mark is
sir, we
pointing.
can see the shadow, sir. We can see the
okay,
shadow over
okay.
here.
I thought it's pierced. That's what was
No,
surprising.
it's
That's all. Okay.
yeah.
But it's a
So
beautiful, yeah. Would I remove it if it had not been affected for 6 years and it's stationary? I would only observe
yeah.
with a vision of 6'9", right?
Yeah, sir.
Yes, sir.
6'9".
Yeah, yeah.
So
I have seen quite a few of these intravitreal eyelashes. So, in fact, the day before yesterday, I was operating a case of sidrosis. The patient had an iron foreign body. He underwent cataract surgery some time back, around 6 years back, and now he presented with RD. So when we were taking out the foreign body, we found that there was an eyelash inside the eye. And once it happened, so that patient had a penetrating injury with a wire. So I could see the kind of thick line which was there. So I thought it was a wire. So when I went inside, that was immediate post surgery trauma, sort of, not 1 month types. So when I went inside, actually it was not a wire but a eyelash. So I feel whenever there is a penetrating trauma and when there is something which goes at high impact, the eyelash goes with it inside, and that's the reason if you see the tapered end of the uh, eyelashes towards the posterior pole, what appears to me from the photograph, and the base of the eyelashes towards the anterior side. So it goes the opposite way round, because once this something takes it along, the tip of the eyelash goes posterior and the base remains the anterior.
Okay. Good. So again, interesting image. And regarding this thing, regarding the image of Apurva, may I ask Anand sir, especially the multicolor imaging? We have attended classes by Dr. Anand sir. Multicolor image, the importance of multicolor image in this retinal astrocytic hematomas.
Yeah,
Anand sir,
as you can see,
yes, sir.
yeah,
Yeah.
as anytime there's an elevation, as Purva rightly pointed out, it shows up as a greenish kind of a hue. So
Yeah.
it helps you define that a little more, a little better. Uh, in terms, you compare the multicolor image with the image next to it, the pseudo color image next to it. You can see the definition is seen far better on the multicolor because it's a, three wavelength laser generated image. So it's seen much better. But of course, by far the most interesting is the OCT image, which shows that moth-eaten appearance and the fact that most of that material is emanating from, the nerve fiber layer and around. So I think that's what makes it beautiful. Beautiful images and well captured, great teaching material. Terrific.
Yeah.
So
And
congratulations.
also see the first image. Apurva has put lot of efforts to this. So again, for the for all the people who are submitting images, we have to put some effort, do some homework. You see how beautiful she has, the I must not say edited, but she has made it the lesion look more prominent, or it stands out. So we have to do some homework before submitting the images. Just like that, they don't get the awards. Congratulations, Apurva, and
Thank
thanks for
you.
the
Thank you. Thank you.
yeah. And
Did you do
regarding
autofluorescence
yes,
on this photograph?
which one, Vinod sir?
Autofluorescence.
Apurva, autofluorescence did you do?
Sir, I don't have autofluorescence of this patient. Yes, I'm sure it would have been very interesting. It would have been hyper AF depending on the amount of calcification.
Yeah, because this is one of the original lesions, amongst the second being optic disc brucin, which are known to be
Yeah,
autofluorescent.
Absolutely.
correct. So a simple non-invasive test, it will clear the diagnosis. So yeah, regarding this particular image, again, I would invite everyone, especially Kim sir, if sir is there. These kind of foreign bodies are definitely challenging, and probably they have put PFCL to protect the macula, and particularly the role of PFCL versus visco, whether visco like viscoelastic substances having any use in this, or any particular uh, tips sir wants to give us for the management of these kind of difficult and large and slippery foreign bodies. Kim sir, please.
Chittaranjan, this, I mean, you're talking about the removal of the foreign body.
Yes, sir. This removal of the foreign body.
Yeah. No. I think surgery-wise, it's not very challenging. And this is not really slip play. What I've had a graphite thing that went inside, and that was like, they usually break. Whereas these ones should be very easy to remove if you want to remove it. If it is superficial and it's not stuck to the retina. And even here, I mean, we have had eyelashes removed from the eyes in the past, but I don't think it is a challenge in removing these eyelashes.
No, sir. I am asking about this image, the glass foreign body, sir.
Yeah, glass foreign body is definitely a challenge. That's what I was saying. Glass is also okay, but something like a graphite and
Mica, sir. It was Mica, sir.
Those are the ones that are really challenging. You hold it with the forceps, it breaks easily. It actually becomes, and the edges are very sharp. Those are some things you really find it difficult in bringing it up. You can't even use PFCL. PFCL actually sometimes pushes it down, and there are problems with that. It depends on the surface, the size of the foreign body, things like that. But that's the only one I've had a lot of challenge in removing it long back.
Correct, sir. So, any other points from the panel, Naresh sir?
Actually, Chito, for this case, no,
Yes,
that
sir.
Vapai's forceps is
Yeah.
one of the great this thing for removing this irregular slippery what do you call foreign body like this. And second idea is you can actually, instead of injecting PFCL, ideally we can go for injection of silicon oil also, because when it dips in the silicon oil, it goes slower, and it is sometimes it will be floating, and it is easy for us to remove the foreign body rather than maybe over the PFCL. We can top it up with usually we top it up with silicone oil, and then we try to remove the glass foreign body. But if it's a small foreign body, you can leave it, because most of the glass foreign body are inert actually. If it's a small one and if there is no detachment, we can just leave it.
Naresh, depends on the location and whether it is mobile.
Yes, sir.
That is very important.
That is true.
So
Anand sir,
I
you
just
want
like to
to say
add that, in this, when it floats on top, when it's sitting on top of the PFC, it'll sit like this. But if the orientation becomes vertical, it can really go right through that PFCL bubble. So that way, it's a challenge. And, another forceps that can be used is my colleague, Dr. Prabhu, has developed this, forceps which is, self-retaining, the reverse action. So once you grasp it, you don't need to exert a lot, because one issue, this is of course pretty thick, which is a challenge in itself, but otherwise if it's a thin one, it can even break when you hold it. So that's another issue. That's a problem. And you've, at the first grasp, you got to grab it, and you need to orient it. So your mind needs to be clear, and you need to have a clear plan in this. And this kind of case, I just wanted to ask the presenter, what instrument did they use, and did they actually sacrifice the lens, or did they bring it out to a sclerotomy, which I think is a difficult thing to do? probably bring it out through the anterior route. These kind of things are probably better managed that way, bringing it out into the anterior chamber, keeping it on, using the iris as a shelf, keeping it there, and then changing your hands, and then by manual just removing it through the anterior segment. That very often is the least traumatic way, because once you grab it and once it falls, this being so sharp, it will cause a lot of trauma. And that trauma, secondarily, once that falls, it will start bleeding, and then you have a really tough time. So it needs to come out in the first go. Yeah.
I think Chittaranjan, I think it's a time up. We can.
Yes, sir. Yes, sir.
Yeah.
So, yeah, point very well taken. And regarding this particular case, this challenge, and we have all very nice points from all our experts. And with this, we come to the end of this felicitation ceremony for the months of January to June 2025. And may I request Dr. Kim sir to say a few words encouraging all the winners and also the participants, those who are regularly submitting images. Dr. Kim sir, please, and also a few words about our image competition monthly that we are doing from VRSI.
I think Chittaranjan, the first person I want to congratulate is you for persistently trying to get this going I remember the days when you had tough time getting people to submit these images. And today it's so nice to see so many young people participating. I think you really brought a lot of change in this process and the way people look at it. And this is a lot of learning just by seeing these images. I think you're doing a wonderful job, and I want to congratulate every winner for taking so much of effort. This really brings out the interest that all of them have, and there's a lot of learning for everybody in looking at these and seeing these images. Thank you. Thank you for doing this. On behalf of VRSI, I'm really happy and congratulate you for doing this continuously.
Yes, sir.
This is one team that has been really doing this on a regular basis. Thanks to you, and thanks to all the winners who have made it really interesting. Very, very good images that I saw. Thank you.
Thank you very much, sir. Also to mention, during Anand sir's period, they started this thing, so we're just carrying it forward regularly. And thanks to all the panel, Anand sir, Binod sir, Padmaja madam, Rajiv Raman sir, I think because of the OPD, so he could not join. And to all our image committee members, Naresh sir, Unni sir, Sangeet sir, and Manisha madam, and to all our VRSI EC members, and congratulations to all the winners. So with this, we come to the end of this felicitation ceremony. Thank you, everyone.
Thank you.
Thank you.
Thank you. Thank you, Chittaranjan. Keep up the effort. Yeah.
Thank you,
Thank you, sir.
Chittaranjan. Thank you, everyone.
Thank you, sir. Thank you, sir.